Hello everyone. After discussing the basics of hemolytic anemias, now let us discuss about hereditary spherocytosis. Hereditary spherocytosis is a condition which will have predominant extravascular hemolysis. I have told you in the when I discussed about the properties of mature RBC that the integrity of the cell membrane is maintained by the cytoskeletal structure, electrolyte and water content, and the amount of membrane lipid. Now, in this condition, there is defect in the cytoskeletal structure proteins. Now, let us first discuss what are the normal cytoskeletal proteins. As you can see in this image, so this is the cell membrane. And you can see that there are various types of proteins that is anchoring the cell membrane with the cytoplasm. Now, what are these proteins? We have certain transmembrane proteins like band3 and glycophorin. This is glycophorin. So, band3 and glycophorin, these are the transmembrane proteins. Then there are certain anchoring proteins like ankyrin, band 4.2 and band 4.1. And these anchoring proteins are connecting the transmembrane protein to the cytoplasmic proteins like the spectrins and actin. Okay. Now, cornerstone of this structure is the spectrins, because the spectrins will make tetramers. Okay, as you can see here, they are making tetramers. These tetramers are combination of heterodimers. One heterodimer is made up of one alpha spectrin and one beta spectrin. As you can see here, one heterodimer is made up of one alpha spectrin and one beta spectrin, and two heterodimers are joining to form a tetramer. One more thing you can appreciate: on one side, this heterodimer is connecting to another set of another heterodimer, and on the other side, it is connecting to the actin cytoskeleton. It is connecting to the actin cytoskeleton, and this actin is connected to the glycophorin through the band 4.1. Okay, so these are all the proteins. The most important protein is the spectrins. However, the most common protein that is affected, that's get affected in patients with hereditary spherocytosis is ankyrin. So that is what you have to remember. So even though spectrins are the most important proteins, ankyrin is the most common protein that is defected in hereditary spherocytosis. And ankyrin mutation will have autosomal dominant pattern of inheritance. So if you see hereditary spherocytosis, 75% of the cases are autosomal dominant. 75% of the cases are autosomal dominant, and the most common cause of autosomal dominant hereditary spherocytosis is mutation in ankyrin. Sometimes they may ask, what is the cause for autosomal recessive HS? Now, this is caused by mutation in spectrin. Okay. I'm telling you the most important points. That means, if they ask you what is the most common protein that is affected in HS, answer is ankyrin. Most common pattern of inheritance, answer is autosomal dominant. But if they ask you most common cause of autosomal recessive HS, answer is spectrin. Okay, so these are the important points you have to remember. The next important point is, what are the other proteins that can cause HS? Now, it is very simple to remember. So all the vertical proteins are affected in HS. I mean, mutation in any of these vertical proteins can cause hereditary spherocytosis. What are the vertical proteins? As you can see here, so band 3, band 4.2, ankyrin, and spectrin. So this group is known as the vertical group of proteins, and they cause defect in these proteins can cause hereditary spherocytosis. Okay, but the most common cause is ankyrin, and most common cause of autosomal recessive HS is spectrin, especially the alpha spectrin. Okay, this condition is usually found in patients in the Northern Europe, and where the prevalence is around 1 in 5,000. And in Northern Europe, this is probably the most common inherited cause of hemolytic anemia. Okay, now if you understand this, now we'll see what happens. What is the pathogenesis? Now, because of this cytoskeletal protein defects, the membranes will become weak. Okay, so if you have a young RBC, it will have its normal biconcave cell. But gradually, because of this weakness of the membrane, they will start forming these microvesicles, and gradually these microvesicles containing the membrane content, they will gradually shed off from the RBC membrane. As the membrane is getting out from the membrane, as the membrane microvesicles are setting off, gradually this RBC, the biconcaves of RBC will make a structure like this that is known as a sphere. So they'll make a sphere for a given volume. The smallest possible diameter, is for the sphere. So they'll make this sphere. Okay, spherical RBC. So that is why the condition is known as hereditary spherocytosis. Hereditary spherocytosis. Now, as they make this sphere, now they are less deformable because they do not have the extra membrane, so they cannot negotiate through the splenic cords of Billroth or the sinusoids. They are less deformable. And further process we have already discussed when we discussed about the extravascular hemolysis. Okay, so they're less deformable. They'll get trapped inside the splenic cords of Billroth. Once they get trapped, there will be erythrostasis. That means stagnation of the RBCs. The stagnation of RBCs will cause further release of potassium and water out of the RBCs. Gradually, there will be reduction in the pH and reduction in the glucose because the pH will reduce because of the anaerobic metabolism that happens inside the RBC, and there will be accumulation of the lactic acid. And also there will be reduction in glucose because all the glucose are being utilized by the RBC, and they are not getting more and more glucose because they are trapped. They are stagnant inside the spleen. So ultimately, they'll end up in the extravascular hemolysis where the phagocytes or the macrophages will come and they will phagocytose the RBCs. Okay, and because of this stagnation and because of increased phagocytic activity, there will be splenomegaly. So all those things we have discussed in the extravascular hemolysis. So this is what happens in patients with hereditary spherocytosis. Now, if you see the clinical features, this also we have already discussed in extravascular hemolysis. We are going to get anemia, splenomegaly, and jaundice. Anemia, splenomegaly, and jaundice. And also we have pigment gallstones. Remember, in hereditary spherocytosis, up to 50% of the patients will have this pigment gallstones. Now, if you see the anemia, like if you ask me what is the severity of the anemia, remember in hereditary spherocytosis, the severity of the anemia is variable. It is variable. I mean, like any other autosomal dominant disorders, usually they have incomplete penetrance and variable severity, variable expressivity. So that's why these patients also will have variable severity. That means some patients may be completely asymptomatic and they will get diagnosed in adult or elderly age, and some patients may present in the childhood itself, or some patient may present during some kind of stress like pregnancy or infection. It depends on the degree of penetrance. So they will have the anemia will be of variable severity. They'll also have splenomegaly, and the spleen size can increase. It can increase up to 0.5 to 1 kg. 0.5 to 1 kg. The spleen can be moderately increased, and also they will have jaundice because of indirect hyperbilirubinemia. Then what you are going to get in the peripheral smear? So in the peripheral smear, you are going to get the spherocytes. So how do you identify the spherocytes? Okay, so as you can see here, this is a spherocyte. And you can appreciate that the spherocytes, they do not have the central pallor. If you compare with the normal RBC, this is the normal RBC. As we have already discussed previously, the normal RBCs will have central pallor because the hemoglobin content is less compared to the entire volume. The hemoglobin content is less. But what happens in a sphere? The surface area is reduced. Now the hemoglobin in the RBCs, they can fit into the hemoglobin can fit into the RBCs. So now they will lose the central pallor. So this is how you identify the spherocytes. Okay. So from this you can understand that that the hemoglobin concentration inside the RBC is increased because the total volume is reduced. So the concentration of the hemoglobin is increased. So in these patients, we will have an increase in mean corpuscular hemoglobin concentration. And usually in these patients, it is more than 34. It is more than 34. Okay, so RBC morphology will be spherocyte. So we'll have a spherocyte. And the MCHC will be increased. It is increased more than 34 usually. What you have to remember is the spherocytes. These are not specific for hereditary spherocytosis. That means spherocytes can also be seen in various other conditions. As we will discuss later about autoimmune hemolytic anemia. Remember, autoimmune hemolytic anemia. This is the most common cause of spherocyte in the peripheral smear. Okay, so spherocytes are not specific for HS. They can be seen in other conditions. And the most common cause is autoimmune hemolytic anemia. So sometimes in the question they may ask, they'll give a picture of hemolytic anemia and they can give this peripheral smear and they can ask what is the next step. So next step is we have to do a direct Coombs test to rule out autoimmune hemolytic anemia. First, we have to rule out autoimmune hemolytic anemia because that is the most common cause for spherocyte in the peripheral blood. We'll discuss about this in the subsequent lectures. Okay, so this is about the clinical feature. They will have variable anemia, they will have variable splenomegaly and jaundice, and 50% of the patients will have pigment gallstones. Now, how will you diagnose this case? I mean, what are the investigations we have? So first one we need to read is about the osmotic fragility test. Osmotic fragility test. Because of these membrane alterations, they will have reduced increased osmotic fragility. So these RBCs will have this increased osmotic fragility. As you can see here, this is, I mean, if you keep these RBCs in sodium chloride, the saline, and if you gradually reduce the concentration of this sodium chloride, normally what happens? Normally at around 0.5% of sodium chloride, the RBC starts getting lysed. The RBC start getting lysed if it is a normal RBC. But what happens for this spherocytic RBCs? These RBCs have increased fragility. That's why they will start having hemolysis at around 0.7% of saline. Okay, so because of this increased osmotic fragility, they can start having hemolysis at 0.7% of saline. So that means there is a rightward shifting of the osmotic fragility curve. So if you see a report of osmotic fragility test, and if they want to give a diagnosis of hereditary spherocytosis, they write that the curve is shifted to the right side. Okay, so I hope it is clear. So osmotic, there is increased osmotic fragility, and that can be demonstrated by the osmotic fragility test. We have certain other investigations like EMA dye binding test. What is EMA? EMA is using 5 maleimide test. Maleimide dye binding test. So this dye, this EMA dye, it will bind to a protein that is band 3. It will bind to band 3. Now we need to understand in this vertical association, even if with mutation of any of the protein, mutation with mutation of any of the proteins in this vertical association can alter the band 3 stability. Okay, so even if there is mutation in ankyrin, there will be secondary damage to the band 3. If there is mutation in 4.2, there will be secondary damage to the band 3. And if there is mutation in spectrin also, there will be secondary damage in band 3. So whatever may be the cause for hereditary spherocytosis, there will be damage to the band 3. And because of this, the EMA dye, it will not bind to the band 3 of a patient with hereditary spherocytosis. So if you see the fluorescence by after adding the dye, if you do the flow cytometry and look for the fluorescence, there will be reduced fluorescence. So this is how you diagnose hereditary spherocytosis in EMA dye binding test. Apart from that, we have other investigations like we can study the membrane proteins by STS gel electrophoresis method, and we can also do ectacytometry, and you can confirm the diagnosis by genetic methods, by identifying the mutation. Anyway, these are not important. You need to understand about osmotic fragility test and EMA dye binding test. Now coming to the last section about the complications. Gallstone related complications, as you all know, the gallstones can cause polycystitis, and splenectomy related complications because the predominant site of this RBC destruction is spleen. This condition is treated by splenectomy. So if the patients are symptomatic, we have to go for splenectomy, and that is the treatment for hereditary spherocytosis. If you do splenectomy, there will be some splenectomy related complications. So these can be seen if the patient has already undergone splenectomy. These splenectomy related complications we'll discuss when we will discuss about the spleen. Now, sometimes these patients can have exacerbation of anemia. Now, this exacerbation of anemia can happen because of hemolytic crisis, which occurs during some intercurrent infections. Some certain viral infections certain viral or bacterial infections can actually exacerbate the hemolytic crisis. And there is one more crisis, that is aplastic crisis. Now, all the patients who have hemolytic anemia, there is increased risk of aplastic crisis. Aplastic crisis means there is transient halt in the process of erythropoiesis. As we have discussed previously, the patients with hemolytic anemia, there is always increased erythropoiesis, which will try to compensate for the RBC destruction. So if there is a halt in the process of erythropoiesis, that can lead to severe anemia because of this aplastic crisis. Usually the patients with hemolytic anemia, they are prone to develop this parvo B19 related infection of the precursor erythroblasts. Okay, because of increased erythropoiesis in these patients, these precursor erythroblasts, the pro-erythroblast, they will tend to express an antigen on their surface, that is the P antigen. Okay, antigen P will be expressed on the surface of the pro-erythroblast. Now, this P antigen act as a receptor for the parvo B19 virus. Okay, they act as a receptor for parvo B19 virus. And once this virus identify this P antigen on the pro-erythroblast, they will infect this precursor and they will inhibit the further erythropoietic process. So there will be a halt in the process of erythropoiesis. Usually this condition is self-limited in 1 to 2 weeks. So during that period, you have to keep the patient on transfusion support. Now there is a special morphology you have to remember whenever there is parvo B19 related transient aplastic crisis. So they will cause this giant pro-normoblast or giant pro-erythroblast. Giant pro-erythroblast. And also you can appreciate that there is an inclusion inside this, and this inclusion is nothing but the parvo B19. This is the parvo B19 virus inclusion. And they will cause this giant pro-erythroblast. This is sometimes called as the lantern cell. Okay, and this is true for any of the hemolytic anemias. Okay, so coming to the last section, this is so what you can understand from this peripheral smear, you can see there are many elliptocytes, elliptical RBCs. So this is a condition known as hereditary elliptocytosis. Okay, and this is caused most commonly by the spectrin mutation, especially the alpha spectrin. Okay, so that is all about the hereditary spherocytosis. In the next section, we'll discuss about the G6PD deficiency related anemia.